Good morning, everyone, and I really thank the audience, the organizers, for inviting me to talk on this topic. I've been working in this for a long time. As Madam said, I'm a pediatrician, but I really got interested in emotional and behavioral difficulties in children and adolescents. And then I was fortunate enough to get the formal training as a child psychiatrist in Australia. The field here is in child psychiatry is still emerging. The basis, the main bread and butter of child psychiatry is the family therapy, which does not exist at this stage in India. I'm sure it will come, but I think there is a big epidemic of mental health problems and mental health disorders in young children, in parents, in all the population, particularly increased after the pandemic. And everyone is confused, everyone is stressed. Children are confused, they are just exposed to a lot of information on the media, but just they don't know how to contain themselves, and they also don't know how to use this information wisely. And here we as a pediatricians, we play a big role in maintaining the mental well-being of children, young people, families, and we also play a big role in early identification of mental health symptoms and early detection, early diagnosis, early intervention. Because what we know is 75 to 80%, but in my population where I work with children with severe mental illness, the symptoms starts in very young age, even preconception or in the newborn period. And pediatricians are really have got the opportunity to do the early intervention or early detection of the signs and symptoms, so that the serious consequences in the adult is prevented. So I can talk about this topic for days and months. I can continue talking, but in this given time limit, I thought what I will give you that the principles of what we use in assessment, diagnosis, and intervention in child and adolescent psychiatry. So what would be useful for you as pediatrician when we talk to children, young people, and families. If time permits, I would like to talk about family therapy, the principles of family therapy that I use in my practice. These are the common psychiatric illnesses we see. There are not many, so we don't need to know the many diagnoses in child psychiatry. There are very few. And diagnosing is not difficult because we've got the Bible, DSM and ICD, which tick the boxes and we give the diagnosis. For example, anxiety, depression, mood disorder, psychosis, substance use disorder, internet use disorder. These are all the common psychiatric illnesses that we see in the silent young people that we see in my practice. Gender dysphoria or gender identity disorder, it's coming up now. But there is mainly the gender identity, the adolescents getting confused about who they are, what their identity is, which is a common developmental phase, which is also coming up now. And in there, there is this same-sex relationships, which is now getting widely accepted worldwide. And this same-sex relationship, it is not a pathology. It used to be a disorder in DSM-3, but since then they have removed that DSM diagnosis because it is a normal variant of one's sexual awareness, who they are. So but these people, because they are in minority, they are at risk of depression and anxiety, substance use, suicide, self-harming. There's high chances in these people. So we have to keep in mind when we work with people who have got these relationship, same-sex relationships, and support them as much as we can. And that comes from the acceptance in the first place, and then you treat them. Somatic symptom disorders, functional neurological disorders, non-epileptic seizures, somatic complaints, very widely accepted in the society as opposed to the mental health symptoms. Many of the mental health symptoms are presented as somatic symptoms. This is called somatic symptoms. We see quite often. and they are going to come to you as a pediatricians. Anorexia nervosa, disordered eating. We had a case presentation yesterday in the workshop. This is how they present as a form of control of expressing their emotional distress. Obsessive compulsive disorder. I saw a 4-year-old child with OCD, varying symptoms of OCD. Very no doubt about checking the symptom, questioning the mother. This 4-year-old, is that 4-year-old going to go to a psychiatrist? No, they are going to come to the pediatricians. Post-traumatic stress disorders, complex trauma, developmental trauma, ongoing. We see a lot of kids in India. I think they are all under the carpet, but they still exist. Dysregulated mood dysregulation disorder, which is a very new diagnosis, where the kids or young people are in heightened states of emotional arousals and the aggressive behavior, getting very common now. There are comorbidities. You see a lot of people with neurodevelopmental disorders, autism, learning disabilities, specific learning difficulties. They are very active. Mild symptoms, mild autism, very prone to anxiety and depression. Learning difficulties, very prone to anxiety and depression. These comorbid psychiatric illnesses are treatable, but they are readily missed in this age group. Lot of children present in acute situational crisis. Acute stressful situations. We had 2 unfortunate events in the last week or 10 days in Latur. That was a result of the acute crisis, that the poor frustration tolerance. The kids were not able to manage their distress and they took their lives. Is there something that we can prevent? I'm sure these kids who have committed suicide, they would have had lots of struggle growing up or in their early years that was missed. And our role as prevention of those unfortunate events by acting early. We see a lot of kids with grief and losses. These are not spoken about. A death of a family member, no one talks about it, but then that can easily turn into anxiety or depression. Lot of these kids, with the diagnostic assessment, we can tick the boxes. So for depression, representing sadness, loss of interest, loss of interest, poor concentration, and so on. We have the symptom checklist. The age of presentation can vary from preconception period to young children, adolescents. Even a baby shows the signs of distress when the parents are stressed. So, varied age of presentations, we have to be mindful of what are the symptoms and what to observe for. As pediatricians and young children, we assess by observation and parenting complaint. But for observation, we need to know what to look for. You can, most of the children and young people, underlying presentation is the inability to tolerate the distress associated with the symptoms, which is the unpleasant. All the emotions and feelings that they go through during them, they are very unpleasant. And as a reaction to their distress, they show the behavior. So most of the young people or children present, we see as presenting with the behavioral symptoms, internalizing behaviors such as withdrawal, self-harming, and externalizing behaviors such as aggression, verbal physical aggression, bullying, lying, and emotional distress. So these are the things that you can look for when you assess a child presenting with these symptoms. Lot of children present with the maladaptive coping strategies when they are not able to handle the distress. For example, self-harming, self-destructive behaviors or substance use. Because they cannot cope with their distress or emotions, they have to deal with some ways. They don't have the emotional language. They don't have the ways to express how they are feeling. And then there is no understanding or acceptance of negative emotions in any family. So when a child goes to the parent and says that I'm sad today because I got bullied at school, the parents say, तुला काय कळतच नसेल, तूच काहीतरी वाईट वागला असशील. So this invalidation prevents them from talking about emotions, how they are feeling, and then that leads to these symptoms of mental distress and mental disorders, what we say. The principles of assessment we use in child and adolescent psychiatry, obviously we are all doctors, we take the history, we take positive, what are the presenting complaints, how they progress, what are the duration, what is happening now, what are the precipitating factors. We also talk about, we also keep differential diagnosis in mind when we assess the history. So history taking in psychiatry or in children and adolescents with mental health problems, it is a skill, and it needs a lot of practice to assess a child. What are the principal important thing is to how you engage the child in an age appropriate manner. So for a baby or a toddler, it's the observation. It is the interaction between the mother and the baby, or a mother and a child. What does mother do when the child approaches to her? Is she warm? Is she loving and caring? Or is she dismissing? Or is she too controlling in the play session? These are all the observations you see to get an understanding of what happens for that mother and the child, or what happens in the child in the family. I will talk about the family assessment at the end, but what we do is, particularly for adolescents and even for young children, you see the child on their own. You modify your assessment and interview based on what they understand. And then you also talk to the parents separately. But doing a dyadic session between a child and a parent, you can observe a lot in that 10-15 minutes, is how the child interacts with the parent, how the parents interact with the child, how the parents interact with them together. Are they able to collaborate and work together, or do they keep fighting in the sessions? More and more they become comfortable with you as a doctor, they will fight in the session. You get an idea is what's happening in that child's life at home, because we'll come to the etiology, but we need to find the etiology of why this child is here with me today. We also modifying the interview or sessions as per the child's age as understanding, which is very important. If a child is coming to you with school refusal symptom, you don't straight away ask them, "Kare shala kashi hai? Avarte ka tula?" It's not obviously going this. There is a lot of, if a child is failing the exams, it will be a lot of shame for that child. What is going to be, if the child is failing, is he going to have a self-esteem or a self-confidence? No, there will be a lot of shame and guilt inside that child when he comes to you. So you have to keep all those things. Being sensitive to the child, to the parent, is very important. It is one of the other principle is to assess the insight of the child and the family. What is the child's symptoms? Is the child understanding, or a young person understanding that he or she is getting angry, or what is the impact of his anger or the behavior in his functional life? Or is the family accepting of the child's distress or behaviors, or is the family dismissing of the symptoms? We as a doctors always do the medical investigations, rule out the organic causes before you label the child with before you label the diagnosis of functional disorders. So aim of the assessment is to identify the factors that are contributing to child's presentations. There are multiple factors. The child is in the center, but around that child is lot of things happening with the school, the family, the peer group, the expectations, extended families, and so on. So aim of is to, what are the factors that are contributing to that child's presentation now? We know in psychiatry, we just not look for the diagnosis of the, we don't look for the symptoms, but we look for what are the factors that are affecting the child's presentation. So biological factors, there is a genetic vulnerability for mental health disorders. Psychological, coping skills, social relationships, family relationships. Cultural issues play a big impact on the child's presentation and how the symptoms are handled, even how the emotions are handled in the family. So it's important for us to know what is happening for the child in the family. Social pressure is getting more and more with the increasing social media exposure, peer pressure, family circumstances. Looking for all these factors is important when you do an assessment. When we look for any diagnosis, and if someone says to me that this child is presenting with generalized anxiety disorder, it does not tell me anything apart from, yes, it's the anxiety disorder, it ticks all the boxes with DSM. What is important for me to understand is what are the factors And this is what we call as a 4P models. What are the precipitating factors? What are the predisposing factors? What are the perpetuating factors? What are the maintaining factors in the family and in the child's life that the child is continuing to present with the mental distress or mental disorders? And the last thing, we always forget what are the strengths in the family. We always keep on labeling that child as a naughty child, तुला काय कळतच नाही, तुला अक्कलच नाही, तू बावळटच आहेस, so on. But you forget that that child is very good in sports, he's a good singer, or he's a good artist. We forget that. Or even with the families, he काय family मध्ये as. But we always need to look for what are the strengths in the families. So the aim is to work with the weaknesses, but then, but also to build up on the strengths that will help with the self-esteem with the child and for the family. So this is the table that I use. It's very helpful that I find. Is the 4P model. What we look for what are the biological predisposing factors, what are the precipitating factors in the biological column. So combining with this model gives you the understanding of what the child is presenting with. Attachment is a thing that I use it very often. It starts in the very beginning when the child, immediately after the child is born. So what we describe attachment, a secure attachment is the caregiver paying attention to the child's emotional needs and approaching in the way that the child is finding helpful. And the secure attachment is very important so that the child is able to understand his or her emotions, but at the same time able to communicate his or emotions to the parents, because he or she knows that there is a secure attachment. I will get the response that I want. I will get the response that I feel helpful. And if there is an insecure attachment, that means whether the parents are dismissing or disapproving, then in that cases, the child will not talk about their emotions to the family home. Because we see, how many of you experience that the parents come to you and say की हा मुलगा माझ्याशी काही बोलतच नाही हो, त्याचं काय चाललंय मला काही कळतच नाही. It's because of the child having the experience that when he or she tried to talk to the parents, he did not get the response, he did not get the emotional comfort. And all these patterns start from very young age. These are the types of attachment styles. This itself is a big one-day workshop, but I use attachment-based intervention is the one that I use a lot in my practice. Again, we're looking at a diagnosis. Yes, it is easy to diagnose someone with, say, postnatal depression or generalized anxiety disorder, but that doesn't tell me what is happening for that person. That does not give me an understanding or information about that individual. For that, what we call is a formulation. So we formulate, we understand the case, so that we can target our intervention. So what are the maintaining factors? Whether we can mitigate those maintaining or precipitating factors. So this is a big example of formulation that I write in my notes or my reports. Is a lady presenting with these complaints. This is a genetic predisposition. This the current symptoms are precipitated after the birth of the baby, where there is increasing stress in her, where she is not able to cope. There is a long-standing pattern of emotional dysregulation that she has learned to cope with using alcohol or self-harm. And then there is a background of sexual abuse which was not addressed. And then her symptoms are appearing to be impacting on her bonding with the newborn baby, and also ability to parent effectively her older child, who is now showing the symptoms of oppositional behavior disorder or regression in her milestone, and so on. So this is the way you understand a person who comes to you, rather than saying just this is a generalized anxiety disorder or depressive symptoms. Intervention is a community-based intervention, outpatient-based, or in my country there is a acute mental illness or exacerbation, then we admit the patient to the inpatient unit. We also have units who admit families for a week or so.
Ma'am, time is up. Time constraints, ma'am.
Having the So multidisciplinary intervention is very important. Then we widely use medication because medication, there are lots of myths about medications, but they are very safe in young people. Sometimes what we know is a combination of psychological intervention and medical intervention. And medication works best, particularly in moderate to severe cases. We use a lot of SSRIs, antidepressant, anti-anxiety medication, antipsychotics we use, and some medications to assist with the sleep. Psychological counseling is to give the strategies for the child or young person to manage the distress, and the specific therapies such as CBT, DBT. We use a lot of therapies to help the child with the distress or treat the illness. Treatment of comorbid conditions. ADHD is a very big, responds beautifully to medications. And inpatient admissions if there is a risk. I'll just tell you the principles of family therapy. Family therapy is something you cannot work alone with the child alone. It's important for you provide education to the family to accept the symptoms, to respond to child symptoms appropriately. At the same time, you also work with the other stakeholders. For example, schools. Education of the school teachers is very important because the teachers are now dealing with lots of behavioral problems, don't know what to do. There are education is very important for the teachers and other. The aim of the parenting is not to teach them how to parent, because every parent has their own style. But the aim is to give that authority to the parent, to be a parent, to have a control, at the same time understanding the child's emotional needs and understanding what the child needs at that time. And also one of the way is to improve the communication between the child and the parents. And most important is to improve the relationship between the parents as a couple. Because many of the times what we see here is the child is the symptom bearer of the family dysfunction. And it is very easy for the parents to focus on child's problems so that they don't have to look at what's happening between the parents as a couple. So this is, again, family therapy is a big topic. My passion I use a lot, and some other time I will come and talk about family therapy for you guys. But thank you very much for coming. And on a lighter note, it's good to be here after a long time, many years. We used to come to Latur in my undergraduate, postgraduate days to watch movies. And the movie I remember watched here is Hum Aapke Hai Kaun. So it's a first of its kind movie focusing on family relationships and family connections. And here I'm now talking about family therapy. I thought this was a coincidence. Thank you very much.